related to tech support, please contact telehealth. You'll see telehealth there, which is Agnes. And for those of you interested in receiving a certificate of attendance, please remind yourself to fill out the evaluation form, which will be sent at the end of rounds today. So with that, I'm passing it over to Einat.
Thank you so much, Stacey, and thank you, Agnes, there behind the scenes for supporting us. I'm Einat. I'm the clinical manager for the behavior support services for the Toronto Central region at Baycrest Health Sciences. And as we developed, I would say that as we developed today's theme, we felt that there is no better way to end the calendar year that has been, I would say, more than challenging, to say the least, with celebrating some of our successes. The perspective of the science of positive psychology is that in order to solve a challenging societal issue, it is not enough to understand the barriers and the causes behind it, but in fact, it is just as important to learn from those that succeeded despite all of those. So today we will be learning from some of our best behavior support frontline clinicians working across various sectors and their success stories. It is my pleasure to invite our first speaker, Simonne Cumberbatch, who is our behavior support clinician lead at the Community Behavior Support Outreach Team at Baycrest. Bear with me while I pop up your slides, Simonne, but the stage is yours.
Thank you so much for that warm welcome, Einat, and sharing such similar thoughts as we all have as we wrap up a challenging year and move towards with hope and hopefully restfulness to the next year to continue to the good work that we do. So I'm going to ask that we start on slide 2 for myself. Yep, that's our entry here, and I'm going to meet you there as well. So today I'm going to share a story about Mrs. S. This client was referred to the CB SOT via the Virtual Behavioral Medicine Program, or VBM. VBM was brought in by Baycrest Outpatient Clinic, where the client had been linked to both social work and geriatric service. Their assessment and her increasing behaviors determined that VBM was necessary, and then VBM determined that we, the CB SOT team, were necessary. We often work in parallel with them, and we work collaboratively, focusing on pharmacological and non-pharmacological ways to optimize care provision and behavior management. This client was also supported by a home and community support service, who did report that the PSWs were going in, but often having difficulty with successful care delivery. She was also followed by a family doctor who reportedly felt pretty overwhelmed with her increasing dementia care needs, and the main behaviors outlined at the time of that referral were delusions, hallucinations, agitation, and exit seeking. Next slide. So Mrs. S was, when we met her, she was living with her son, and she had moved in there with him due to a failure to thrive. Before that, she had lived in the family home, and she had lived so independently and alone post her husband's death 8 years earlier. Her husband had actually had a history of infidelity, the family shared with us, and he had been a very controlling and strict spouse, both with her and with the kids. Mrs. S had 3 children, a son and 2 daughters, and they were all involved with her care. The daughters reported that mom was resentful but dependent on her husband for most of their life, and always strongly favored her son. Her son was the main caregiver, as supported by his wife, and he presented to the team as quite frazzled and emotional under the burden of caregiving. While married, Mrs. S was only allowed to do odd jobs here and there. So for the vast majority of her life here in Canada, her main purpose and role was that of a homemaker and wife. Medically, she was quite stable, but she did present with a decline in cognition that included loss of English because she did gain that. Her first language was Italian. She was often forgetful, very perseverative with questions. She had lost literacy and showed declines in attention. She had no insight into these changes, but she did remain able to complete her ADLs, though she needed some support and supervision with this, and she could complete some minor task involved with IADLs. Next slide. So the family reported that Mrs. S's behavior of main concern for them were her delusions. The main delusion that she had was that her son was her husband, and because of this, she was very possessive and defensive of him. This resulted in significant verbal and physical agitated responses, towards her daughter-in-law and granddaughter, usually happening when they spoke or interacted or were close to him because she believed that he was cheating on her. She would also anxiously follow the son around the home, including trying to go into the bathroom and bedroom with him, which could sometimes result in sexually inappropriate responses from her. This was, of course, very upsetting to the family, especially the son. The client also experienced audio hallucinations where she would speak to her mother. And because of this, she would believe that her mother was close by or waiting for her at her childhood home. When you added to that her disorientation, because she would also often believe she was in Italy or that she was still in the home which she owned prior to moving into the son, this led to her having a strong desire to seek out her childhood home or to seek out her mother. These symptoms were most profound and progressive in the afternoon. At that time, she would often become very restless, difficult to redirect, difficult for the family to manage, and would respond very, very poorly to the family's attempt at either redirecting or a reality orientation with her. At that point, they had a PRN that was prescribed by the family doctor, and they were using it quite sporadically. Next slide. Client was really a collaborative work. We had a MOCA and GDS completed by the Baycrest outpatient team. We had a medical screen from the family doctor, the GP, to confirm that she was clear of infection. We had a PISAs and informal interviews and observation by CBSOT, and a global geriatric assessment and psych assessment by VBM. Together, we created a plan that included a full medication reconciliation and included CBSOT, myself, coaching, and included in that was how to redirect using GPA and validation strategies, how not to challenge delusions, but to focus on the underlying feelings, and helping the family set up an environment so that Mrs. S could have meaningful engagement within the home, including simple food prep and sweeping, because she really did believe that it was her house and she should have a role and a purpose, of course, as we all would want for ourselves. We also used child locks on the main doors so that the family wouldn't have to intervene when she was trying to get out. But we left the back door open, which allowed free movement into the gated gardens so she could safely go outside as much as she wanted. We also provided education around dementia and its progression, and of course created a care plan which both the family and PSWs could use. I worked with the family about bi-weekly, and I always supported the VBM collaborations. And by the end of that 2-month period, the client had stabilized beautifully. All the BPSD, those symptoms were significantly declined, most notably the delusions and hallucinations, and the family felt so much more better able to manage her. The daughters and daughter-in-laws were clearly most keen about the non-pharmacological approaches, and they really dug in. Whereas the son was a bit more focused on the medication and thinking that it was that fixed his mother, but collaboratively they made it work. The family GP was somewhat nervous at the discharge, so the Geri Psych team from VBM did offer to do call-in consultations anytime he needed within the next few months. And so he felt that he was in a place where he was better supported. So overall, we felt this was an extremely successful case, and we discharged. Next slide. But just 8 weeks later, we had a re-referral. The son had called his home and community care support service care coordinator and was pressuring her to do a re-referral, citing that the client's behavior had come back and more. The care coordinator contacted our Baycrest clinical navigator and was really pushing for a priority re-referral. She also reached out to CBSOT requesting that the client be seen ASAP. Now, before things started rolling, I did kind of press the pause button, and I advised that we needed more information to be shared and requested that we have a same-day consult where we could sit with the care coordinator to figure out what was really going on in the home. During that discussion, the care coordinator shared that, as per what the son was saying, Mrs. S was irritated, notably disoriented, incontinent, having challenges with ADLs, experiencing hallucinations and delusions all over again. He believed that she needed new medication so she could be fixed right away and stressed the need for VBM. However, due to these significant changes occurring in such a relatively short space of time, especially with new clear takeaways here is how important continuity of care is. Because I had worked with the family prior, I understood how rapidly overwhelmed the son could feel and his understandable fear of the behaviors coming back, as well as his belief that medication was the only answer. And because of that, I understood his reflex to press the panic button and to demand access to VBM, sidestepping his family doctor because it had worked so well in the past. Because of that knowledge, I was able to look past his initial anxiety to assess objectively around what really might be going on in the home. Continuity of care can really result in that kind of quick analysis because we already carry the client's history with us and a knowledge of them. And that brings us to the next point, the really good work that we all do around establishing rapport. This focus on getting to know the client as more than a single person, but incorporating the family and informal supports and being aware of the various dynamics into our assessments, this leads to a more complete understanding of the presentation, and it allows us to provide care in a more holistic manner. Another lesson to take away is not being afraid to press pause. It's easy to get swept away when there seems to be an emergency or a need for quick fix. But in our rush to help, we can lose track of what's going on and we can miss what our gut instincts are telling us. So it's so important to trust your clinical judgment. And if something doesn't feel right, voice it. Lastly is the importance of working collaboratively with our care partners. We know that there are things about our clients and their situation that we keep within our minds because not everything can be written down in the notes and you can't really document your intuition. But with open communication with our fellow care partners, we're often able to spot something that we might otherwise have missed because we took the time to communicate and respect each other's judgment. You know, the care coordinator did stop and she did go through these things with me, even though she was facing that pressure to re-refer so quickly. So I think it's here that we end with our title. Some things just aren't in the notes. And often it's those soft skills of communication, intuition, and rapport building that saves us time and solves the puzzle. The slide after this one is actually my last slide. And I just like this one. This is obviously not the client, but I really like this one because this is how I imagine her now, because I know that the daughter-in-law now allows her into the kitchen and she helps with the prep of every meal. And it's a bonding time for them. So this is how I like to imagine her at the end.
Thank you so much, Simonne, for sharing this this case that had its ups and downs and really emphasizing the piece about continuity and clinical judgment. I'm wondering if anybody has any comments or questions for Simonne regarding this case. I wonder, Simonne, we used the acronym VBM. VBM is a fairly new program. Do you mind saying a few words about what VBM stands for, just for those who might not know what it is?
Sure, of course. I think I skipped my note, the actual reading of it. So thank you. It's a virtual behavioral medicine program here at Baycrest. It started as a bit of a pilot in the beginning of the COVID pandemic as a way by which people could virtually access psychogeriatric assessment that is usually provided inpatient by the Baycrest. You know, we're always trying to get people, especially in the community, into our BSUs and our behavior units. And that unit, because of the amazing work that it does, often had a very long wait list for entry. I think we had a meeting this morning and one of my coworkers had mentioned that at one point in time, there was as many people waiting on the list that it would take a whole new unit to hold them all. So the VBM was opened as a way that the people could have access virtually and quickly towards geriatric assessment. And it's just been amazing that we can get that sort of work with medication and with assessment and with observation via the virtual means.
Thank you, Simonne. I will just clarify for those who don't know the subtleties of what we're talking about. When we say geriatric assessment, we don't mean the actual geriatric assessment. We mean just for responsive behaviors. And often those cases are cases that have already been seen by a geriatric psychiatrist in the community and a behavior support team. And it's the most extreme cases that actually are referred to this program. I don't see any other questions, but a lot of warm words for you on the chat that you might want to have a look, Simonne. And with that, we'll move on to the next story from the acute care environment. We have Milena Silva with us, who is a social worker by background and is a behavior support clinician with UHN, part of the behavior support services team for acute care. I will pop up your slide in a minute, but please do take it away, Milena.
Thank you, Annette. And thank you, Simonne, for sharing such a wonderful case. Okay, so good afternoon, everyone. Today I'm going to be sharing our case study on Mr. G and his transitional path. At the end, I'm then going to summarize some key factors that made this a successful story. So next slide, please. Mr. G was an 89-year-old male who was living alone and mostly independent with his ADLs. He had been admitted to hospital after being found with a decreased level of consciousness, dehydration, infection, congestive heart failure, and delirium. The client also had a series of comorbidities to consider, which included heart failure, hypertension, and bilateral hearing loss. While in hospital, although the client's medical issues resolved quickly, the client now exhibited a lower level of cognitive functioning than he had prior to admission. The client was aware of this and expressed concerns about his quality of life moving forward. He also began to voice suicidal thoughts. Mr. G's friend and power of attorney expressed concern around him being able to manage his ADL safely and independently at home alone. With his medical issues resolved, but unable to return home due to his new baseline in functional ability, the client became ALC. Next slide, please. While in hospital, Mr. G began to exhibit a series of responsive behaviors, such as wandering with risk of elopement and requiring a one-to-one constant observer, yelling, refusing care and medication, suicidal ideation, and impaired sleep. BSS used a collaborative approach to work with the client and staff to identify potential behavioral triggers. Some of the triggers identified were feelings of loss related to his independence, understimulation, and lastly, due to the client's decrease in cognitive functioning, he was experiencing increasing disorientation and memory impairment, which often led to the client misinterpreting the environment and people around him, and then causing him more distress and responsive behaviors. So after we identified the triggers, the following behavior outcomes were noted and a plan was put in place to help prepare Mr. G for long-term care. BSS recommended the team discontinue the use of a one-to-one observer, as this is not replicable in long-term care and poses a barrier to admission. We also recommended a review of the client's medication, with the goal being to reduce the amount of care runs required. Lastly, BSS advised that in order to decrease agitation, the team would need to consider opportunities to increase engagement. Next slide, please. So strategies were provided to help address these concerns, and Mr. G was then moved to a transitional care unit to await long-term care. Unfortunately, this change in environment led to an increase in behaviors and the transition was not successful. Staff were experiencing challenges related to adapting the client to the behavioral support plan that was set out by the BSS team. Mr. G expressed more verbal and physically responsive behaviors, resulting in the need for code whites. After only 1 week, Mr. G was repatriated back to acute care and readmitted to the same unit. Next slide, please. BSS and the acute care team regrouped and collaborated again to help better prepare the client for a future transition. This included providing further support to help manage the responsive behaviors that had recently emerged. One way that BSS supported this was to provide more education to the team in terms of Mr. G's care preferences and ensure that everyone was aware of his care plan. We provided a more individualized plan for the client by preparing the staff with information on the client's history, his social story, and care preferences. For example, we highlighted that the client responded really well to a warm, friendly, and welcoming approach, but didn't like to feel rushed and was not comfortable with having care forced on him. This approach helped to establish a trusting relationship between the client and staff, which made him more willing to accept care. He also began to sleep better and more consistently through the night, requiring fewer and fewer PRNs. Lastly, to increase the client's sense of belonging, BSS also suggested the team provide a cake and make a big celebration for the client's upcoming birthday. This was important for the client and it helped him to feel instantly welcome in his new environment. Next slide, please. So here you can see that a community of healthcare professionals was needed to support our client to ensure he transitioned safely and successfully to the long-term care home. BSS collaborated with the nursing staff, social workers, and Jerry Psych to create a plan that was individualized and meaningful for the client. For example, BSS provided supports and strategies around discontinuing the use of the constant observer. Since this could not be removed from one moment to the next, staff needed to work together to decrease the amount of time the constant observer was available in small and regular increments. The client usually required an activity outside of care points, as he would not receive many visitors during the day to keep him company. One strategy the staff used was to encourage the client to walk around the unit. Mr. G could not recall the location of his room, which happened to be next to the nursing station. The staff would direct him to go around the unit to get back to his room instead of directing him straight inside. This worked for many reasons. First, the client was able to engage in a safe activity at his own pace, which also provided him with some exercise and variety to his day. This also helped the staff to buy some time if they needed it, such as if they were waiting for staff to come in to provide care, or if they needed to buy time until his next meal. Because the team was aware of Mr. G's care plan and the need to increase opportunities for engagement, this meant that everyone on the unit was able to redirect the client as needed. And this was from everyone, from nursing staff to administrative staff and even cleaning staff on occasion. Next slide, please. Here we have a bit of an overview of our case study. So first, the client was admitted to the hospital and received treatment for his immediate medical needs. This involved receiving support from the social worker and clinical nurse specialist, and they provided support with disposition planning and help to address responsive behaviors. Next, once it was determined that the client could no longer return home safely and he became ALC, BSS was involved to assist with transition support, behavior management strategies, and advocacy. BSS involvement also included working closely with the staff who were in regular contact with the client. BSS then collaborated with the acute care team and completed a report highlighting evidence of the client's optimal behavior management, and a long-term care application was submitted. BSS provided further advocacy and support by initiating a transitional care conference with the receiving home and liaising with both the BSO and long-term care leads to share information regarding the client's care plan. The care conference also provided a space for questions and concerns, as well as an opportunity for open discussions around the client and his needs. Lastly, BSS was available for the handover to ensure a safe and positive experience for both the staff and Mr. G. Next slide, please. So in summary, our team would like to leave you with the following key factors for success that you can begin to implement with your own cases going forward. These are collaboration, an individualized approach, and regrouping. First and foremost, it's important to remember that we do not work in a silo. Our BSS team may have received a referral to support the client, but we do not approach this task alone. We work collaboratively with a community of professionals to ensure that our clients are receiving the best care within the most appropriate environment for their needs. The second factor for success is to ensure your plans and strategies are individualized for the client. Using Mr. G as our example, BSS consulted with the team to help create a rummage box that could be used during times when the client was understimulated. Some clients will receive lots of visitors to keep them company. In the case of Mr. G, however, he did not have many regular visitors, so the team needed to identify and create specific activities that he could do on his own, such as sorting cards, building with Legos, or working on puzzles. It's also important to note that it doesn't matter if the client is doing the activity correctly, such as completing the puzzle. What matters is that the activity has meaning for the client. The last factor for success that I would like to share with you is to remember that not all transitions will be successful. That is both okay and to be expected. What matters is that the team regroups, identifies what went wrong, and makes a new plan. Sometimes the client is not a good fit for a particular long-term care home or vice versa. However, just because the client does not transition well into one unit does not mean that they cannot transition successfully into another. By leveraging these three factors, collaboration, an individualized approach, and regrouping when the transition did not work out the first time, BSS was able to successfully help Mr. G transition to a long-term care home where he felt welcome and accepted. And that's all. Thank you for listening.
Thank you very much, Milena. I wonder if this was a great demonstration, not only on collaboration and transition, and I really like the emphasis that you've put on setting the environment in acute care to fit what would work in long-term care and kind of doing that thinking ahead. That was very powerful. I'm wondering, there is a lot of warm comments. I'm wondering if there is any questions from Milena about this case presentation. None? Anything coming up on Q&A or chat, Stacy?
No, nothing yet. I can put anything that comes up in Q&A in the chat for Milena to address.
So we can resort to those cases also at the end if we have a few minutes left. But what's great about the next story, Milena, is that the next story tells a similar story, but from the other side, from the long-term care side. So transition as it looks in acute care and transition as it looks in long-term care. And what's nice and what we have in behavior support, which is very special, is that connection between our community clinicians, our acute care BSO clinicians, the behavior support leads in long-term care home, and our behavior support outreach teams and clinicians in long-term care. And we can really work together to smooth and support teams through those transitions. So thank you again, Milena, for this great case presentation. I will move to introduce Margie and Kaur. Margie and Kaur are both registered nurses in long-term care. They work at the City of Toronto Long-Term Care, Castleview, Wychwood Towers Long-Term Care Home. And they will also be sharing with us a story about transition and what they have done with their team to innovate and to ensure smooth transitions. So without doing too much of a spoiler, let me share your slides, Kaur and Margie, and you can take it away from there.
Hello, good afternoon, everyone. It's nice to be part of this education rounds regarding success stories. My name is Margie.
My name is Kaur. So today we will be presenting about our revised approach to transition. So some situational background. So our interprofessional team worked hard throughout the COVID-19 pandemic.
Can we get the next slide, please? Okay.
Thank you. So our interprofessional team worked hard throughout the COVID-19 pandemic to keep our residents safe and to prevent the spread of a virus. From March 2020 until the end of March 2021, admissions were on hold. So there was a need to get the patient out of acute care into long-term care homes. Castleview started receiving multiple complex admissions starting April. We had at least 30 new admissions in that quarter. Many of our residents had diagnosis of mental health and or dementia with behavioral expression. Some of the behaviors posed a risk to COVID-19 exposure to both staff and other residents. Next slide, please. So our goal here in Castleview is to know every person coming to their new home and provide them a transitional support and follow up as needed. The interprofessional team revisited the admission process. Castleview began to include a more extensive assessment by involving the in-house BSO leads, which is both of us, for all new admissions. Team revised the in-house admission checklist to include more detailed and comprehensive assessment. We also, the BSOT, Baycrest Sport Outreach Team and Geriatric Mental Health Outreach Team were automatically included if the resident have a behaviors of past psychiatric history, or as needed if we need them. So our revised new admission process is, as said earlier, the in-house BSO leads are extensively involved in new process. BSO lead review all admission notes received from LIN, RAI assessment, or any other notes attached to the admission package. These might be not limited to past psychiatric assessment or other behavioral support assessment. Every new admission, specifically residents who have behaviors, are started on one-to-one monitoring and DOS monitoring for the transitional support and to know the baseline. Next slide, please. Oh, I think I already went through a slide, yeah. So next slide, please.
Yeah, sorry, we're talking fast. Okay.
So after BSO reviewed all the notes, now it's our part to do our own assessment. So after reviewing the notes, we do our own assessment, and this might be including like interviewing a resident or family member if they're available, to ask how they feel about transition to long-term care home, any past psych history or any suicidal history, or if they have any concern or suggestions about their transition, how their transition can be made successful to long-term care home. Behavioral assessment and safety assessments are also completed by us. After all the assessments are completed, we create a safety and behavioral care plan by involving our unit staff, nursing staff. So now I will give it to Margie. She will talk about case study.
Next slide, please. So our case study, we have Mrs. P. She's a 90-year-old Portuguese female, and her diagnoses are Alzheimer's, MDD or major depressive disorder, and panic disorder. She was previously living at home with her son, who has a mental health diagnosis. Resident had a long-standing contentious relationship with her son. The son served as a primary caregiver, but the daughter is the official power of attorney. The son and the daughter do not agree on the care, and the son had a very difficult time supporting his mother's care needs at home. Neglect at home led to crisis for long-term care placement, which the Castleview. Next slide, please. So our observations upon admission, when we're talking about now responsive behaviors, there was an intense and rapid mood fluctuations, such as crying and yelling 1 minute, then laughing in an ecstatic manner the next. She was verbally and physically expressive during personal care. She would hit, scratch, and throw her shoes at the staff. When left alone, she yelled and called out. She also attempted to get out of her chair unsafely, and she walked around in a restless manner across the room in the hallway. Expression of responsive behaviors were actually worse in the evenings, and she also experienced poor sleep. Her PRN trazodone was ineffective. Next slide, please. For further observations, her behaviors worsened after the visit of the son. The son used to stay and sleep in his mother's bed, which is actually in Castleview. She would use her walker to barricade the door and push staff out of her room. She disturbed her roommate also during the night. We also identified her having high risk for falls, and she had 3 falls since admission. There was an incident as well. The son took the mother out of Castleview and went to their house. Daughter called police, and the mother was returned by the police to Castleview. So this is a very intense admission that we had. Also, son had difficulty adapting to his mother's stay in long-term care and threatened to take her back home. Her daughter requested that he will not be involved in decision-making. So for next slide, what interventions we have done for this particular resident. So once our assessment was done as BSO leads, we work with the staff to initiate a 24-hour admission care plan, safety care plan, and mood or behavioral care plan that was needed upon admission. So we always work with the staff with that. We always have DOS monitoring, that's mandatory, and we always start high intensity one-on-one by PSW for 72 hours, for close monitoring and supervision to ensure the resident's safety and to provide transitional support. For this particular admission, we identified that she needed more than 72 hours. Next slide, please. So for the intervention, this is with collaboration and with the help of our 2 external resources. We have the BSOT, the Behavioral Support Outreach Team from Baycrest, and our GMOT from Toronto Western. So we did pain assessment or management. Resident was started in schedule and PRN analgesic for pain management. That's one of them. We also encourage the resident to participate in dementia care program. We have it's being practiced in the home right now. They were successful and very effective with doll therapy, Portuguese music, and towel folding. And fortunately, the dementia care is also Portuguese. She was excellent and they had a great relationship throughout the transition. We also did the pro attention plan. It was very successful. And with the help of our GMOT, we started a low dose of risperidone for her BPSD. The home, we also use the in-house transition support checklist. This is actually similar to guiding checklist in supporting successful and sustainable transitions in long-term care for older adults with responsive behavior. So this is under BSO support in the webpage. So it's similar to what we use for her. So what is the outcome? Next slide, please. So for the outcome, resident was able to successfully transition and adapt to her new home, which is Castleview. She established trusting and positive relationship with the staff. She is now calmer, sleeping well, and participates in care activities, especially the dementia care program. Overall, her behaviors are improved, her behaviors of verbal and physical expressions towards the staff. And also the son continued to visit the home, and he expressed satisfaction of the care of his mother. I'll give it back to Gaur for more outcome.
So yeah, I will discuss now how we receive after we receive the feedback from the staff. So overall, staff on the unit felt more supported. Residents and families were appreciative of one-to-one support during the transition period into long-term care home environment. Changes to admission process have also resulted in improvement to the initial assessment. Team was able to address the diverse and challenging behaviors issue in more robust and comprehensive manner. Next slide, please. So lessons we learned: teamwork and collaboration with interprofessional team promoted more effective communication. The change initiative improved the use of resident-centered care strategies and encouraged more individualized care planning. Communication and involvement of frontline staff in care plan was shown to be vital to the successful and sustainable implementation of interventions. BSO leads will continue to follow up and provide support to residents and staff on the unit. Next slide, please. So take-home message are: the ability to change and pivot due to unusual circumstances is an example of creating in-house capacity through interprofessional collaboration. BSO lead role is a vital and huge during admission process for smooth transitioning of the resident and supporting their family members. This is also a best way to identify risk behaviors and provide safety to both residents and staff on the unit. We identified the new circumstances in a timely manner that using our knowledge, skill, and expertise in our behavioral management. We took ownership of the current situation and exercised our problem-solving abilities. Next slide, please. So our motto here is that every resident who comes to long-term care home has a unique life history. And that's it.
Thank you so much. Thank you for listening, everyone.
Thank you very much for this great presentation. It was nice to see transition on kind of both sides of the, I guess, the journey. But also it's quite evident that you had in both cases, we've seen quite a complex or challenging case that is multi-layered. And it was very interesting to see how you've tackled each of those layers. I wonder, Margie and Gur, with all the flood in transitions that we've been seeing into long-term care home after that has been held for a while, and maybe it's a question for you, Milena, as well. How do you do that comprehensive work with multiple transitions that are being admitted to the home at once? Maybe you could relate to how you could still kind of maintain the best practices and standards of care, but in light of that rushed environment or that flood of transition that we've seen in the past year.
Answer or Milena?
Either. Could just
Okay.
jump in.
In Castleview, the checklist is very, very important. So I know we're talking about quantity right now, like we have at least 30 in that quarter from April to June. So to be able to say that to achieve quality with that quantity, like 30 of them, we use our checklist, our transition checklist, that we make sure we covered everything from reviewing the notes, conversing with families, and other important information. And then we also do our documentation. So that's very helpful. So we can move forward to the next case, because actually not all the cases are, we can rate it by very difficult transition to some are, not so bad, but there are really, during those times, there are really complex admissions.
And also, I think when we receive admissions, there is always a cap that you can only receive 1 or 2 admissions per day and 5 admissions in a week. So it's not a rush that we're not missing anything. And sometimes if on admission, we have extra registered staff on the unit to support the unit so that the staff and the resident is supported if they have, because the admission is a very comprehensive and you're busy with other tasks too. So I think extra support is also important.
Yeah, to add that, we don't admit on Friday and weekends. And the sheet, sometimes it's most available ahead of time. The package, the admission package is ahead, sometimes a week before or a few days before the admission.
So there is a question also about the transitional checklist. I just want to say this is all based on the BSO provincial checklist and tools, and they're available on the BSO provincial site. I wonder if I can call on you, Simonne, because I'm sharing slides and I'm not able to do an active search. If you, I know you're very familiar with those tools, if you could post some of those links on the chat for folks to check it out and put it to use. Milena, before we move to the next, next story, any quick comments from you regarding that question?
Yeah, just to add that as much as possible, leverage help from your team, the people that you're working with. They're always, I know in my experience, they're always happy to assist in any way that they can, and opening the lines of communication. If you don't know something, ask. And that is always just keeping the client paramount in the situation to ensure that they have a successful transition.
Thank you for that great comment, Milena. I'm going to just share the slide and introduce our next speakers. I want to invite Joan, who is a registered nurse, behavior support nurse in our long-term care behavior support outreach team at Baycrest, as well as invite Veronica Downer, who is a behavior support PSW in our long-term care behavior support outreach team at Baycrest. And they will talk to you about building confidence in building staff confidence in care. So thank you, Margie and Gur, for your great presentation. Please stick with us for some questions at the end. And Joan and Veronica, the stage is yours.
Thanks so much, Inat. Hi, good afternoon, everyone. So welcome to listen to Mrs. M's story. So let's meet Mrs. S. Mrs. M. Next slide, please. So Mrs. M is a 72 years old female admitted from a retirement home a few days ago. She had no recent medical changes. However, since she admitted, she refused the care, even vital signs check. She started hitting, punching, kicking, biting, grabbing, required 2 to 5 staff to provide her care, especially shower. And she smells feces at the time too, tried to wash her hands in the toilet. When staff tried to intervene, she splashed her hands towards the staff. She also had a physical expression towards co-residents. She pushed somebody who suddenly fell and also punched another resident on the chest through fluids when staff tried to intervene. She pisses a lot in the unit and comes to other people's room, taking over their belongings, respond with physical expression as well. So staff have tried some gentle approach, low approach, and also giving her a snack as well as iPod, but nothing successful. We are very exhausted and thinking that the resident need to be admitted for further assessment. Next slide, please. So let's look at her background. Mrs. M has a university degree. She worked as a physical education teacher before. You can see how strong she can be, right? And she had Alzheimer's disease, hypertension, arthritis, expression aphasia. Her meds that time including trazodone and also held PRN injection, glutamine, as well as Tylenol for mild pain. She likes all kind of outdoor activities like kayaking, swimming, golfing. She used to have her own cottage. And she prefers gentle approach, dislike noise, loud talking, and being rushed or disturbed. So I take this case, I did, next slide please. I did pieces assessment and also asked staff did the doors to try, find out behavior patterns at the time. And also do a delirium workout, just try to, work out delirium. Next slide, please. I also, according to my assessment, I give them about 12 recommendations to try out. And I also invite our team PSR with Veronica who come over to do more intensive observation, try strategies, as well as try to implement my recommendations. So let's welcome Veronica to share what you found. Veronica, you're on mute.
Sorry about that. So hi, everyone. Thanks for being here this afternoon. And I'm so happy to be a part of this round, taking this opportunity to share this case with you all. So during my observation for Mrs. Hem, these are the following contributing factors that were found. Number one was privacy. Mrs. Hem is a very private person. She wants to maintain her dignity. She said too many people involved, as 2 to 5 staff were trying to manage her care, washing her while holding her tightly and talking to her together. Also, her lack of trust to the LTC staff were, an impact on her care, especially how staff have to wear a face mask and shield. I also found bowel incontinence increase or feelings of embarrassment and anxiety. So staff need to approach her in gentle manner and provide assistance to her as needed. Also her need for autonomy, the lack of opportunities to participate in care. She said, I can do it myself. And finally, new social and physical environment. Feeling lost in the new environment and not knowing anyone. Next slide, please. So here are the successful strategies that we try to improve care safety and compliance. Trust was the first. So first of all, I need to build trust. So I started to spend time with Mrs. Hem. This was very instrumental in overall effectiveness of providing interventions and support to the staff. For example, I engage her in conversation and offer her opportunities for her to tell her own stories and validate who she is, showing her sensitivity, providing her with magazines and doing puzzles with her, giving clear information and check her understanding and her unique needs as well, which really helps to build up the relationship that generates her instant trust to me and was more comfortable to approach and tell me that, she needs to use the washroom. And this was a significant improvement. So working towards our care goals together, we established the routine toileting that reduced smearing. For meaningful activities, she was encouraged to participate in activities with the activation staff, which reduced pacing and more engaged, and increased also positive interactions and increased interaction also with staff and other residents, as well as safety. Next slide. The most challenging part was her shower. So knowing the staff was not comfortable to provide her care by 1 or 2 staff, and without pre-med care, I tried her shower one day 3 alone and let the staff and lead observe in distance. Mrs. Ham is able to communicate her needs and her wants and needs when she is calm and rested. So I approach her friendly with supportive manner, give time and space for her to process information, and let her be active and participate in her shower, maintaining her sense of control, asking permission to assist as needed. She was actually cooperative and thankful after shower was done. The staff was shocked to see the difference. And this was the turning point for me to grab the opportunity to share the strategies with the staff and encourage them to try the same. Next, I work closely and in collaboration with the LTC PSWs and the lead to demonstrate the approaches to reduce the trigger and frequency and also severity of the behaviors. This really helped build up the confidence of the staff. They started to do the care 1 to 2 staff over the course of two weeks, especially allowed shower and care. And she also began socializing and interacting positively with the other residents. And here is where the lead really acted as champion by collaborating with BSO team RNs and PSWs and the care coordinator. They huddled with the care team to emphasize the care strategies. And you know, staff were really happy that I was there to support them. Thank you.
Thank you, Veronica. Your excellent job led a great outcome. So we see resident physical expression of heating keeping really reduced significantly. The IM injection, how though? Staff to build up trust with residents and be able to provide her care like most of the time by 1 or 2 staff. So these staff said, I'm okay now, which she used to be struggling to provide her care. Even if said, oh, I did the same as Veronica did, and I found it was successful. The psychiatrist says it's a great job your team have done as a non-pharmacological approach. It is very impressive. Next slide, please. So there here some key learning we feel about. Number 1, we feel establish trust relationship with the resident and LTC staff are very important. Also, integrating the personhood into individualized person-centered care also are very vital. We also found that demonstrating good care approach, technique, and share and coach with staff in supportive and collaborative manner, which really helps build staff skill and capacity, like empower them, listen to their concern, really helps. Last but not least, that lead and management support is very instrumental to help implement the care plan, help improve resident care and safety in the last. Thanks so much for listening, everybody.
Thank you so much for this this great case presentation and great outcome. I want to pause and see if there is any specific questions. I think that your key learnings really summarize well what we've heard from the other cases as well. And there's certainly some kind of common threads around what was effective or what are the factors for effectiveness in those cases. We are almost out of time. I'm seeing one question. Our feedback poll is on the screen. I'm also
there's one question in the Q&A.
Yeah.
Were there any significant barriers to staff buy-in to this approach to care and care plan?
It was in the beginning because staff believed that residents are not able to understand, not able to participate. So after us demonstrating how we did the shower and the care, see the difference, that's the time we're able to overcome the barrier and make them feel, oh, that's another way we can do. Yeah.
Thank you. And I certainly saw a common thread, and I just want to highlight a few points that I've heard from all the cases that we've seen today. First of all, it is quite important to take the time to invest in the relationship, to know the person, to develop the relationship, and to tailor and therefore tailor your intervention accordingly. In all of the cases, we've seen that the non-pharmacological approach supported some kind of decrease in the need for pharmacological approach or one-on-one support that is often not sustainable. In the case, Veronica and Joan, that you presented, the staff at the long-term care went from having 4 to 5 staff involved in care to 1, which I'm sure is a significant capacity building. And you've all emphasized also family involvement and how the family plays a significant role. It's a great opportunity to remind people that in long-term care at Toronto Central, we have the Laura Petter from Alzheimer's Society, who is a caregiver specialist that supports our teams in those cases and supports families in transitioning to long-term care, as well, and educating them about dementia and responsive behaviors. And lastly, I would say it seems to be the theme of our week and the theme of our services. It takes a village. It's really not about doing it on your own. It's really about doing it together, accessing the supports and the teams that you have and getting everybody on the same page and coordinated. So with that, I think we're out of time. I really want to thank our great speakers today, not only for a great presentation, but also for the work that you do day in and day out for our mutual clients and their families. So really thank you all for this and for sharing that today. And I hope that this was somewhat educational to our audience. There's certainly great comments on the chat. Any last words from you, Stacy, about about the survey or?
I've put everything in the chat. Just want to say that this was Einat's idea, the idea of the success stories, and it truly was wonderful to hear from our speakers today, and it was really inspiring. So I want to thank you so much, and thank you, Einat, for this idea. Hope we can do many more like this. And I loved how you summed that up, and just saying that this is our last rounds for 2021, and wishing everyone a restful and a healthy and joyful holiday season. Thank you.
Thank you so much for that great summary, Stacy. Take care, everyone. We'll see you in 2022.
Thank you.
Thank you. Bye.
Thanks,
Bye.
everyone.